afternoon, and thank you for attending this month's Ochin Grand Rounds. Today, we are excited to host Dr. Benjamin Sanders and Ericka Turley of the Jail Health Service Division, Public Health, Seattle and King County, as they present on a jail-based initiation of buprenorphine for MOUD, from pilot to operations. Dr. Benjamin Sanders is a family physician who completed residency at OHSU in 1997, served active duty for 4 years in the U.S. Army, followed by a move to Seattle and working initially as a part-time physician provider for the JHS division starting in 2001. He has served as the medical director for the JHS division since late 2004. Ericka Turley joined JHS in 2019 as the Substance Use Disorder Program Manager. She began her career as a clinician working with women in substance abuse disorders in an emergency shelter environment, though the majority of her 20-plus year career has been spent designing, managing, and evaluating programs to assist people involved with or impacted by the criminal legal system. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Benjamin Sanders and Ericka Turley to present jail-based initiation of buprenorphine for MOUD, from pilot to operations. Dr. Sanders and Ericka, the floor is yours.
Hi, everyone. Thank you. Yes, this is Ericka Turley with Jail Health Services, and we are going to share mostly a qualitative story of how we went from start to finish, starting our continuation program throughout now doing initiation. And we have some learning objectives for you today. And you should be seeing the learning objectives right now. Is that what everyone's seeing?
Yes.
Okay, thank you. So as I was saying, the first learning objective is to describe the buprenorphine medication administration, the challenges that we've had here in a jail setting. The second is to describe the considerations that we've made for MOUD ordering outside of a typical provider-patient visit, and we'll talk more about that in a little bit. And third, we wanted to identify the drivers of and the cost and safety security concerns for bup administration in a jail setting. But first, we're going to go over some terms and abbreviations, acronyms, for those who might not be familiar with our government alphabet soup. OUD is opioid use disorder. MOUD is the medications for opioid use disorder, including buprenorphine. JHS is Jail Health Services Division, and we are a part of public health in Seattle and King County, so King County here in Washington. DHAD is the Department of Adult and Juvenile Detention. That's the organization or the department that runs the jail itself. KCCF, King County Correctional Facility, and we have 2 facilities. This is one that is in downtown Seattle, and the MRJC, which is Maryland Regional Justice Center, and that's our adult jail in Kent, Washington, which is just south of, as a suburb south of Seattle. We're going to say buprenorphine, we're going to call it bup, and it refers to any buprenorphine containing product. And KC, if we say that, it refers to King County. And then, of course, OTP is opioid treatment programs. And as I mentioned at the beginning, we're going to share mostly a qualitative story of how we went from pilot to operations. And Dr. Sanders is going to start just by where we started in 2018. So Ben, there you go.
Yeah, thank you. So where we were earlier than 2018 was that our total jail population between the 2 sites, KCCF and MRJC, was roughly 2,000 people. The daily bookings were roughly 100. It was obviously not exactly that, but that was the sort of general range of our new intakes on a daily basis. We did have continuation therapy for methadone. We have a contract with a local OTP to provide methadone doses for people that were OTP clients, regardless of the regional OTP with which they were connected, as long as they could show that they were active patients of those OTPs, our contract OTP would do what we call courtesy dosing, where the nurse from their program would actually come into the jails and bring people's daily methadone doses and administer to them. We actually were keeping track of the methadone doses in our electronic health record, just so we knew that that was part of the person's medication profile, but we were not actually dispensing or administering the methadone for MOUD. For rare patients who came in stable on naltrexone, we actually did continue those. Mostly these were not patients who were being treated with naltrexone for MOUD reasons, but were receiving naltrexone injections for alcohol use disorder. And we did actually initiate methadone in some patients in order to prevent withdrawal. Primarily, those patients were pregnant, but we do rarely administer methadone for withdrawal prevention for other medically fragile patients to basically keep people from deteriorating and ending up in the hospital. And with regard to opioid withdrawal management, what we do and did in those early days was we treated symptomatically. So we would treat with antiemetics or antidiarrheals. We would give people some electrolyte replacement and some fluids. And we actually authorized ordering those symptomatic medications even before the onset of symptoms, when patients endorsed OUD and said, yes, I am going to go through withdrawal. We did not have any continuation of buprenorphine. So for patients who were receiving bup for MOUD, we basically took them through withdrawal. So what did we start with? Well, in late 2017, we were planning to begin ordering buprenorphine for continuation purposes, but before you can order buprenorphine, you have to have the DEA X waiver. So I directed all of our medical and psychiatric providers to obtain the X waiver. We actually held off on starting that process until it was clear that ARNPs were going to be able to obtain that X waiver, which was not the case originally, for those of you who've been around for a while. But once the ARNPs could obtain the X waiver, I directed everybody to go ahead and go through the required training in order to get it, so that we were ready to go by the beginning of 2018. We needed to develop a report using Epic's reporting workbench so that we could easily report, if DEA requested it, how many patients were being ordered buprenorphine by any given provider, because there are caps in the X waiver program so that you can't exceed them. And we had to be able to, at the drop of a hat, be able to get a report of who was ordering and for how many people. And by June 2018, we were ready to start a bup continuation program. Our numbers were initially very low, partly reflecting the fact that there wasn't a whole lot of community MOUD with bup. And so we had just a trickle of patients coming in initially. Less than 20 were in custody out of that 2,000 total population receiving bup on any given day in the facilities. But as community prescribing of bup went up and we had more and more people coming into the jail on current buprenorphine MOUD, we started to experience a bump in the numbers that we were continuing. And that's when we started to notice just how difficult it was around the medication administration practices for buprenorphine in the jail. So we actually started hitting some real snags when the patient counts reached about 35. And that had to do with, okay, we're back.
Sorry.
That had to do with the process for obtaining the bup for administration. So in our facilities, we actually have Pyxis machines, automated drug dispensing devices, for all of our controlled substances. So any controlled substance, the nurse has to obtain it from the Pyxis. And that means the nurse has to log in and then find the exact patient and enter the order so that it all matches up. And there's really tight accountability for all of our controlled substance dispensing and administration. And as you can imagine, having to do this with larger and larger numbers of people, there were basically lines starting to form at the Pyxis device while nurses were trying to wait for their turn to go in and start entering their patients. It could just be a handful of patients for any given nurse, but the time really became pretty difficult to manage as we started hitting those numbers of 35 and above. Next slide. And what this is just an example of what we were able to generate using a reporting workbench report from Epic. It is really pretty slick when you take a look at this. The reality, though, was since we were querying the active production database, the duration that it took to run this report to be able to get these numbers was pretty significant. I mean, it was taking sometimes upwards of 10 minutes to run the report because it was going in and looking at all active patients, all prescribing things, and then matching them up per the ordering provider. Next slide. So when we think about medication admin for BUP, we wanted to keep going with our dispensing controls through the use of our dispensing devices. And I already talked about how that requires the individual login, patient ID entry. Buprenorphine is a difficult medication to administer in a controlled environment. And that has to do with the fact that it's sublingually administered and dissolved. And what we found when we started off on our BUP ordering program was that the time for dissolution under the tongue was really highly variable. Sometimes it was very clear that the tablet was completely dissolved in just the space of a couple of minutes. And then sometimes the nurses were reporting that the tablets were essentially whole upwards of 10 minutes after administration. So if you can imagine a nurse with a lot of medications to administer, and all of a sudden you're standing there with one patient waiting for over 10 minutes, this was a huge problem. The other thing is that in our environment, when we're administering controlled substances, we really want to make sure that we're not having aberrant drug taking. It could be diversion where the patient is sort of trying to get the medication to be able to sell or to give to somebody else. And that could be something that they're actually profiting from, or they could actually be the victim of threatened violence by another inmate to get them that medication. It could also be that they're sort of, quote, stockpiling. They may not want to give it to someone else, but they may want to just sort of have it around in case they need it at some later point. And our initial plan was to try and group patients who are receiving buprenorphine together. And that would make it possible to do sort of group admin. That was what we were hoping for. But what we realized quickly was that some people on buprenorphine were actually needed as inmate workers. Some people on buprenorphine actually required other specialty housing, like psychiatric or other medical specialty housing, outside of where we had originally planned to do our sort of group housing for BUP patients. And so the reality was that we weren't able to effectively condense in large groups anyway, people that were on BUP, meaning that the med admin practices were affecting multiple jail units, and it was much more difficult to do mass administration of BUP. The other thing is that we thought about, well, you know, there's different formulations of BUP. There's the film formulation as well as the tablet. And there was also this question of crushing the tablets versus using whole tablets. We did a cost analysis that compared BUP films, and that initially showed a daily difference of cost based on our current orders of about $200 per day. Subsequent analysis, though, when the BUP films went generic, showed that the daily difference in cost for just the medication was much lower. It went down to only about $20 of cost difference per day. However, we did find in talking with other jails who were using buprenorphine that actually the films turned out to be easier to divert than crushed tablets. That then led to the question of, is crushing tablets okay? And we had our pharmacists look into that, and we were unable to find any evidence that there was any pharmacological difference with crushing the tabs as opposed to using whole tabs. So we opted to go ahead and crush, as is being done in other jail settings. And then, you know, when we are doing medication administration, it takes time to do, and they have to basically put on hold other processes that are going on in the jail. So if med pass is happening, we can't have patients that are due to get their meds on med pass go out for visitation or recreation and time out of cell. And so what we were running into was that when we had very long med passes associated with these long, sometimes episodes of dissolving tablets under the tongue, it was actually interfering with other jail operations. Next slide. And this is you.
Yep. So going back to when we began continuation, we noticed almost right off that we saw a disproportionate number of people who are white who are receiving BUP for continuation. And it brought up a lot of questions about why that could be. Is it because people coming into the jail are more likely to be served by the community outside? But it raised a lot of questions that we've been monitoring ever since. And we've just now, with the data starting in 2020, have been able to dig a little bit deeper. And so we started, like I said, we started questioning in 2018, but so this data here is for 2020, when we just are now able to kind of, with EPIC reports, pull the data. So it shows this, what this table is. It's a breakdown of the race by the key decision points. And what I mean by that, it's like we start off with the census to compare the number of people screened at booking. And this booking number here is a proxy for bookings. It's screenings, because everybody who comes into the jail is screened by a nurse. And then we then go down the line about the people who are reporting the use of opiates in the last 30 days. So we're looking at the percentages there, and all the way through continuation and then induction. So if you can see, just from the beginning to look at the most prominent numbers, that people who are Asian, and I also wanted to say that these racial breakdowns are what DAJD uses at booking. So we have an interface between DAJD's booking system and our EPIC records. And so we use DAJD's race classifications. It's not what the person would identify as. So here, where people who are Asian are in the King County census are 19% of the population, but when they're screened at booking, it's only 7%. People who are Black are 7% of the population, but at booking, they're 31%. People who are Latinx are 10%, and then at booking are only 4%. And then people who are white, and according to the King County census, are less than 67, it's 54%. So quite a difference. And even going on down the line, let's talk about people who are Black. So if they're 31% of the people who are booked are Black, but of the people who are reported as using opiates in the last 30 days, it's only 20%. And the numbers are kind of consistent going on with American Indians, 2% to 4%, Asian 7% to 5%, Latinx is 4% to 4%. But then again, we see a difference between people who identify as white. It's 67% of people who are screened reporting the use of opiates in the last 30 days. It goes up to 67%. Going on, so of the people who reported using opiates, these 2%, these are the numbers of people who then had their prescription continued and had or were started on BUP during their jail stay. And in order to have their BUP continued, that means a person has to have an active, valid prescription at the time of booking. It also means that they have a UTOX, or we collect a urine sample and it has to test positive for BUP. So out of that population, we're looking at the difference in demographics. So just comparatively, if we go down to people who identify, or people who are identified as Black, it's 12% had their BUP continued. And if you can see down the line, it's if 31% are booked, 20% report using opiates, but only 12% have their BUP continued. It does go up a little bit when we're talking about, we're starting them on BUP. And then for people who are white, the opposite. It's people who are white are more likely to have their BUP continued at 74% of the population of people who are on continuation. And again, that's a little bit more than the people who are reporting the use of opiates. And so we were wondering what this all meant. And so just to kind of see how the disparities were built into the system, how is it that people who are white are more likely to receive BUP for continuation, is, testing to see if it is really a result of more people coming in on BUP, or is it something else? And we were seeing some disparities at other decision points, not just this, but these are just the ones that really stood out. And what this is, it's just it's comparing the rates of people of color at each of these decision points to the rates to people who are white. So it's just the ratio. So what it means that here, American Indians are 2.5 more likely to be screened at booking. So 2.5 times more likely to be booked. Asians are 0.39% more likely than people who are white, and people who are Black are 4.9% more likely. So that's almost 5 times more likely to be booked into jail than people who are white. Overall, the combined for people of color, it's 1.17 more likely to be booked into jail. All the ones with the red exclamation point, it means that, looking across it, that it's statistically significant, that it's not just by chance that this is happening. So if we're looking and going down the line, looking at the people who were asked and then it was reported that they used opiates in the last 30 days, again, we see a disparity or discrepancy between people of color and people who are white, where American Indians, Alaska Natives were 1.13 more likely to have reported opiates in the last 30 days. People who are Asian are 0.75 less likely. African American or Black was 6.68 less likely, where Latinx are 2.47, and overall combined people of color are 0.75 less likely than people who are white to have reported the use of opiates in the last 30 days. And we have our theories about that on it. And I also wanted to call out that the numbers for the Latinx numbers are, these are preliminary metrics as well, because right now the way the jail classifies race, they consider Latinx or Hispanic as an ethnicity, and don't collect it as race. So here, people who are Latinx are pulled out into ethnicity and then included here and substitute. So if they were recorded as white and Latinx or Hispanic in the ethnicity, they were considered Latinx here. So going on down the line, people who receive BUP for continuation, the one that stands out the most is people who are Black, where it's 0.63 less likely to receive buprenorphine for continuation. We were suspecting that because people who are white are more likely to receive it, that this is really kind of how it's impacting people of color down the line, where people of color overall are 0.71 less likely to be continued on their BUP. The last bit of data are the people who we started on BUP, and I just also want to say that our numbers are still really small. Like I said, it's preliminary numbers, but kind of just wanting to take a look at to see if there was any different rates or disparities noted. And overall, it seems like the disparities are going down. Again, it's really early to tell and preliminary. But if we looked at this, less of the information is statistically significant, where it's only Latinx population, where there was 0 comparative, the relative rate, right at the even mark. People of color are just under 1 to 1, so 0.97 as likely. Again, this is early data. All of this data here at the first 3 columns are data from January through October, while the information and inductions are just June to October. So it is, like I said, preliminary, but it's giving us some signs to wonder what's making these numbers stand out quite so much. What in our process is making it stand out so much. So this is what we're seeing now. But I want to take you back to 2018 because, oops. 2018, we had some external drivers of like what got us to where we are today, right? And ACLU of Washington, so namely this lawsuit from the ACLU against the Whatcom County. Whatcom County is a county north of Seattle. Essentially, the ACLU alleged that Whatcom County was violating the ADA by denying people with OUD medications needed to treat their addiction. With this, and they settled in the end. In the end, they settled, and Whatcom County agreed to provide BUP for continuation, withdrawal, and induction or initiation. So they agreed to provide the full spectrum of access to buprenorphine. We took this as a signal or as a warning saying that because we were only doing continuation at this time and just barely getting started, that we needed to expand our program as quickly as possible. And this is pretty common now. If you are to look across jails across the country, is the ACLU, not the ACLU, but the ADA and the regulations around the ADA are widely cited. So this is just something that jails for now cannot get around not providing BUP for opioid use disorder. So this settlement formed the foundation for our desired future state. And the desired future state, and Dr. Sanders already kind of touched on our continuation process, but this is kind of what we were striving for. So we wanted to provide buprenorphine and naltrexone to people with an active verified prescription. So continuation. So anybody coming in with OUD, we would continue their prescriptions as long as we could see that it was active, and that they their urine tested positive for those medications. We also continue medication, methadone, but that is continued by a contracted OTP. So they come in to the facility every day and provide the dosing for the people who come in already on methadone. Our goal was to start an initiation program too. So that means that we wanted to start people on BUP MOUD, and then refer them for community continuation. So we start them here at the jail and then connect them to a community provider upon release. We wanted, so people with OUD who are pregnant and not already on a MOUD, we can order methadone for withdrawal prevention, and Dr. Sanders mentioned that earlier. It's kind of an existing practice of people who are pregnant we don't want them to go into withdrawal, so we do a methadone protocol. And then we refer them to an OTP for ongoing care. Naltrexone initiation is also available when appropriate, though it's rare, and because of it's a tricky as well. So we are now just focusing on BUP initiation. We also wanted to offer withdrawal, and this means that we wanted to make sure that BUP was available for people not interested in being connected to a community provider who are really wanting to ease their withdrawal symptoms while they're in jail. We know that very quickly after someone starts taking BUP, that their withdrawal symptoms subside, and we wanted to replace our existing over-the-counter drugs with buprenorphine. So that was our goal. And now I think Ben, right?
It was about what it would take to get there. So yep. We first had to know what we were talking about in terms of volume, because as I already mentioned, the volume question was going to be a driver of how hard it was going to be to do BUP administration with large volumes. So we checked out some of the other local jails, the SCORE facility, and then Snohomish County Jail. They both were reporting rates of about 10 to 15% of the average daily population. And again, at the time, our average daily population was around 2,000 people. So we anticipated that maybe 200 or even 300 people, or about 10 to 15 of those 100-ish new patients coming into the jail would qualify for BUP therapy. things that were going to drive the cost primarily were staff time. We already mentioned about the time of nurses at the Pyxis, but then, and somewhat about the nursing staffing timing for MedPass. Also, though, the longer the MedPass goes, the longer we will need correctional officer escort to accomplish the MedPass. And the more that we have to prep the automated drug dispensing devices, the Pyxis devices, the more pharmacy time is needed. So there was a lot of essentially staff time that was going to drive the cost. We also wanted to make sure that we were able to categorize, because the ACLU settlement with Whatcom County Jail was very specific that they were going to be asking for reports from that county jail on how many people were on therapy with buprenorphine that were continued on it, how many people were initiated by the jail, and then how many people opted for withdrawal treatment with buprenorphine. And so we needed to build essentially orders to clarify what the category of the patients was going to be. And what that all added up to was a very big number. It was obviously an estimate because we weren't doing it at this point, but we thought through all of the different things that we thought we would need, considering additional Pyxis devices, considering how much time, the MedPass would increase, how many correctional officer hours would be needed. And the total estimated cost was $11 million. That was a non-starter for the county, essentially. So we scaled it back. We said, all right, we're going to have to do something much smaller than that, because trying to start a program that was that expensive was not tenable. So we said, what do we need to do? We need to look at our workflow again, and then we'll go ahead and start doing this, assessing the withdrawal severity so that we don't start the BUP too soon. So we're not going to jump the gun on the BUP orders. But then we've said, well, what's going on with this? The nurses were concerned that we were going to have providers that were going to be basing MOUD new starts on BUP, basically based on a COWS score, a clinical opioid withdrawal score. And they said, gosh, the provider's never even seen this patient, and now they're going to start them on MOUD for their opioid use disorder? What the heck? This doesn't sound right. Some of the nurses actually were concerned. They started looking up what the rules were for BUP ordering, and they found that actually there's some pretty stringent rules by DEA about controlled substance prescribing and the practice of telemedicine. And in those rules, it said that you had to have at least one in-person medical evaluation of the patient before you would be able to prescribe like this. So that took a lot of work to resolve. And it actually hinged on the description of what prescribing actually is. And essentially, prescribing is what it sounds like. It's writing a prescription or having a piece of paper or electronic prescription that goes to a pharmacy for fill in the community. A prescription can be, at least technically, filled at any pharmacy, right? I mean, a patient could bring a prescription and say, I want to pay for this, and the pharmacy either has the medication or orders it, but ultimately they should be able to fill it. It's a valid prescription. However, in our environment, we're not actually prescribing by that definition, because there is no option of other pharmacies to use. It only goes to the in-jail pharmacies, and it's only our prescribers that are able to write orders for those pharmacies. So there is no choice in our facilities. And ultimately, we were able to see that what we are doing is not prescribing, even though in the vernacular we call it that. We're actually ordering medications. So it was something that was kind of a semantic deal, but it actually was really useful for us to get to that place where we could say, okay, we will actually, however, commit to a provider-patient visit after the medication order, but we're not going to require that a provider meet with the patient in advance of the order for BUP. So the nurse would go up, see the patient, do a COWS, get the score, make a call to the provider, and be able to get the medication order, but the provider would not have to see the patient first. And so we were all set. We were ready to go live in early 2020. Everything was all ready to go. And then COVID.
Yeah, COVID affected our timeline considerably. We were hoping to go live at the beginning of 2020. And with COVID, we had to make several, the jail had to respond to several different changes because of the jail population decreasing, moving patients so they're single-celled, and a lot of logistical changes within the jail and within jail health practice. There was, we were trying to reduce movement in the jail, reduce movement to clinic, remove and reduce or eliminate practices that that weren't deemed essential or critical, though we've later have adjusted, and we adjusted as ever since, but it delayed our pilot start, and we were able to start on June 1st. We started small. We really wanted to test our workflows, and it was more considered a proof of concept to make sure that that the way we understood the patient moving through the flow worked as expected. And so we limited it to 5 spots at one time. Only 5 people were inducted. That means only 5 people initiated given BUP on any given day. So as soon as that person was released, it opened up a spot for a next person. We developed Epic recording workbench reports that allowed us to track that. So nurses in real time responding to a patient with their, conducted the cows, the vital signs, and if they were eligible, meaning their cow score was high enough, they would check this reporting workbench to identify making sure that there was a spot open, and then they would could then call the provider and offer BUP at that point. Our pilot also included linkage to community prescribers. And so this is a brand new service as well that started with the pilot or the implementation, where we have a team of medication assisted therapy or MAT specialist team. So these are a group of 3 substance use disorder counselors or professionals who work solely with people with OUD. We started the pilot at KCCF in June, and then we started again after evaluating the workflow and kind of working out the major kinks. We started at our MRJC facility on September 9th, so just a few months ago. A month into that, we transitioned to regular operations. And this means that we've been watching very closely, doing QA on anybody who's been inducted, and when we started the pilot at the RJC, we've worked out enough of the workflow kinks and understanding the process enough that we could move it into kind of a normal operations where we can just do quality checks or PDCA as we go. Right now, as of this month, there are no more limitations or no more limits to the number of spots open at one time. Went from 5 total spots to kind of an overall capacity. So, you know, we start people on BUP for continuation. We're continuing their active prescriptions. We offer for BUP for people who are using it for withdrawal and then these initiations. So we wanted to count the capacity, overall capacity. So, and that's largely related to our medication administration. We have 25 at KCCF and 20 at RJC, and really because nursing staff and the length of time it takes to do the med admin or the med pass for the day really is kind of the driver for the number of people we can serve. So the nurses can get through a shift, so we're not overextending nursing time. And so this is, again, more preliminary metrics. This is what we've seen since the beginning of the pilot in June through September 30th. And we're using a log scale here just so you can kind of see in relative form the comparison between the different work through process. And it's like before, we were looking at key decision points in how a patient moves through our workflow or moves through receiving care. So we started with 41, almost 4,200 SUD screenings Of those 4,100 screenings, 476 of them screened positive for OUD. And so that's about 11% of the total, which kind of actually matches really closely to the original estimate Dr. Sanders mentioned, where we were kind of expecting 10 to 15% of people to screen positive for OUD. Of the 476, 406 of them, so 85% of them, were referred to a MAT specialist. So that's one of our team members who will then work with them to get them to a community provider. So 85% of them were referred. And then of those referred, 298 of them were seen by a MAT specialist for an intake. And that's the full intake. A greater number were actually seen by a MAT specialist for just checking in on them, checking to see if they were currently in withdrawal and at those early stages when they were first booked, but not long enough for not where the full intake wasn't conducted. And so largely, most likely they weren't also referred on to a community provider. Of those that had an intake though, 86 of them, so a very small number of them, 29% were referred, had a referral in the system in Epic to a community provider. And of those, 77% or 66 were confirmed to make it to one or more of their appointments. And like I said, it's preliminary metrics. Our entire team, our use of Epic, where we had to develop complete workflows from the documenting the intake, documenting each of these touch points of how do we measure, like how do we count the referrals, how do we count it that confirm the appointments, and so we had to work with our Epic team to build ways to extract this data from Epic, and that largely brings us to kind of ending it with our pain points. And I know other counties or other jurisdictions have similar challenges. So we just wanted to share our challenges as well. And I think med administration is our largest challenge when it comes to the prep time, when it comes to the process, the length of time it takes, because it's sublingual. If it was liquid, it'd be, you dose it and it'll be done, but the sublingual itself presents a challenge. And then the staff that are required to do the process. So you have pharmacy, you have nurses, you have DHAD correctional officers all involved throughout the process. And it could take up to 4 hours or more to deliver Bupe alone. The legality of the medication and the ordering early on was a barrier we weren't quite expecting. We knew of the regulations. We had been watching closely with other jurisdictions how to handle the legality, but this is our model was just a little bit different because we are doing it all in-house and we don't contract with an outside provider. So because we do our own ordering, we have our own nursing staff and everything, this legality I think was new, was an unexpected issue for us. And of course, COVID also gave us some extra challenges as well. Budget, primarily because of staff, we were expecting 10% of the population, up to 200 people on Bupe on any one given day, and would require a lot of time to do the Bupe admin piece. But it doesn't only include Bupe admin, it's also the time for the deck call or the triage call. And those are the times when the nurses are meeting with the patient before they start Bupe. They have to be in sufficient withdrawal. And so that means the nurses are tending to the patients. The patients are making a request to see the nurse, and that takes time as well. It can take up to an hour from start to finish, from a time a patient requests to be seen by a nurse to the time when the nurse is finished documenting the order. It can take about an hour. So if we're doing multiple inductions a day, you can see that it can add up really quickly. The electronic health record, or EPIC, as I think I mentioned before, our entire team the MAT specialist team, we had to develop our own workflows. We had to develop our data collection process and reporting. We wanted to make sure that they matched with like the Whatcom settlement, but we also have funding requirements. We get funding from several sources, and we had to have data collection pieces for each of those sources, up to, I think, 3 or 4 different sources. And because Epic is so big, and it's complex, it has the benefit of being robust, but that adds to complexity as far as it relates to data collection, and data reporting. And it's one change in a workflow at the very beginning. So for instance, adding a question at the screening has so many implications down the flow, that it can take months to make one small change. And then the pilot project limits on access. So we started at 5, only 5 people being inducted on any given day, and that really kind of didn't sit well with some of our nursing staff or other staff. They were like, why we can serve more? Why are we limiting it to 5? That means we have to tell other people that they can't have it. How do we tell a patient no? And we had to develop entire workflows just in how to communicate this to patients. And it really did affect staff morale. And then, and I mentioned it again, but the MAT specialist team, they're the team that works with the patients upon release. Our team works inside the jail and outside the jail as well. But one of the biggest barriers they face is this unknown release date. So we can be working with the patient, and even when patients have a release date, it can change without much notice. And so people with a somewhat of a plan, or like where the intake was just done, they can be released the next day. And that lack of a release date or lack of certainty prevents the next, making that scheduled appointment or scheduling an appointment and then going with the patient to their community provider meeting. Another gap we have is the lack of bridge prescription or medication. And because we do our own in-house prescribing, our medical providers have their own DAX waiver. That presents issues just for the prescription itself. The prescription ends when their incarceration, their jail stay ends. And it also has the lack of the bridge medication, also because it's a controlled substance. We are hesitant, and we really do not want to put this medication on property. Putting meds on property is a common practice for other types of medications. We have a workflow where where the order is put in, the pharmacy places it, and then it's automatically placed on property. But because it's a controlled substance, we are having a difficult time, and the unknown release dates, we're having a difficult time making sure that patients have a bridge medication when they need it. And one of the reasons they need it at release is because largely this population, it relies on Medicaid for benefits, and their Medicaid is suspended while they're in custody. And so on the day 1, if they're released today, their benefits don't turn on until tomorrow. So and so if I was released today, but I dosed yesterday was the last time I dosed, I could start to go withdrawal before my benefits even turn back on. And so it's the MAT specialists who are scrambling to find a provider on the day of release so they can get the intake appointment, so they can get the prescription and get the patient dosed before they go into withdrawal.
Ericka, I think we may want to wrap up because we're running out of time, and I want to make sure we can address some of the questions that have come up.
Yes, definitely. Well, that's pretty much it. It was an uncharted path, and but we're making our way. So I'll wrap it up there.
Thank you, Ericka and Dr. Sanders. So yeah, we are almost at time, but I wanted to get to this question from Patricia Albaran, who asks, did you remove the plus screen, or did you remove from the plus screen those already connected to an outside community entity?
I think she's talking about with the data that you were showing in the log scale on slide 15, Ericka.
Oh, yes, that refers to people, that refers to only people that we started on Bupe.
All right, thank you. Well, again, we are at time, unfortunately. So I just want to say thank you very much, Dr. Sanders and Ericka, for that insightful presentation. And thank you to everyone who attended today's session. Be sure to follow Public Health Seattle and King County on Twitter at KCPubHealth. That's KCPubHealth. And follow Ochin on Twitter at Ochin Inc. and over on LinkedIn. In addition, be sure to head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. In addition, be sure to visit our Ochin YouTube page where you will be able to find, starting season 5 of Ochin Grand Rounds, that's the one that we're in right now, past Grand Rounds presentations and exciting information coming out of Ochin. And Ochin Grand Rounds is taking December off, but we will return on January 20th in honor of Cervical Health Awareness Month with a presentation from Dr. Amy Weiser of Oregon Health and Science University on an overview of the ASCCP risk-based guidelines for abnormal cervical cancer screening tests. So from all of us at Ochin and from Dr. Sanders and Ericka to all of you out there, have a great weekend and stay healthy out there.